relatively low cost way of improving fertility. When you read a lot of the data, okay, there's a lot of people data that say IUI is a waste of time. Okay, I mean, it's out there. I've just read multiple articles, you know, on it, and I'm thinking, well, whoever wrote these articles doesn't have the babies I've made just by adding on insemination. Whereas, yes, we have high-tech treatment, and in vitro works great. I mean, I can't say it's an amazing treatment, but it's a lot. It's a lot to do. And if you can just show the sperm the way, it's not expensive, it's easy, it's low tech, there's no huge like things involved, and it works. I mean, I have probably, I mean, I was gonna say hundreds, but probably thousands now of babies that all we need, and again, and you know, and you tell the guy, hey, your sperm's great, dude. You're doing awesome. You know, like we really don't need to do this. However, you haven't gotten pregnant in the bedroom. Like, can we just give the boys a little direction? Literally,
yeah, definitely.
We give them direction. I mean, I had a couple from the Keys years ago, and so she had come up, and this guy's semen analysis was amazing. Okay, she had a little ovulatory problem. She was a little excessive in exerciser. And so we said, look, after you've done a couple cycles of plummeted intercourse, if you haven't gotten pregnant, I said, all roads are leading to IVF. So she said to me, she said, well, what can I do? I said, well, we can add IUI. We can just put the sperm in. I said, your husband has, 150 million sperm in his semen analysis. It's hard to think that one of these boys is in your egg. No, it was an obscene.
That was a lot.
It was obscene. But she wasn't getting pregnant. So I said, look, we could try one IUI. If it doesn't work, you need to do IVF. And she's like, all right, my grandmother has told me she's going to loan me the money for the IVF and blah, blah, blah. I understand I'm not getting pregnant. So we go through her cycle, and she's like, oh no, her follicle is ready. It's a Friday. Okay. That means if we trigger her on a Friday, she needs insemination on Saturday and Sunday. Okay. They live in Key West. He is a fisherman. Okay. There is this huge fishing tournament in Key West. Okay. On that weekend. I said, look, I go, we can either do your inseminations on Saturday and Sunday, and he can not fish. I said, and then you're going to need to move on to IVF. She's like, I'll make him do it. So they drive up to Miami Saturday. They drive up to Miami on Sunday. Okay. She's doing a Clomid or Femara cycles a while ago. Okay. She gets pregnant. Okay. And because they live so far away, I don't do their OB ultrasounds. Like their doctor in Key West does them. Okay. I get a Christmas card that year with a picture of her and her husband with these 2 babies. Okay. She got pregnant with twins.
Oh, wow.
I mean,
nice.
Nothing else had worked. Nothing else had worked. All we needed to do was, I mean, this guy, like, the thing is, I wasn't really gung-ho on IUI because his semen analysis was so good and he had so many sperm. We just needed to just give them a little direction. So, I mean, sperm are up against a lot of obstacles trying to make it into that uterus. So, although some of the medical data says that IUI is not as efficient as IVF, which is a true statement, okay, there is still a place for it in fertility medicine. And again, I have the, hundreds, and I would have to say after doing this since 1997, probably thousands of patients that have been successful with this technique. So you can do 1 IUI, which is again going to be beneficial, and then 2 IUIs, which is going to be a little more beneficial. And it's just because of more sperm exposure. So Dr. Dura, what's your exposure, like what's your experience with patients with IUI? Because you see our patients, so.
Yeah, definitely.
What are your thoughts?
I hope that we're crossing our fingers for a few patients right now that are waiting for their results. And I think we work with it just similar to a natural cycle because it's, less, heavy as far as medication wise on your body than IVF. But I noticed we've been getting more IVF IUI questions too. So And definitely we work with Chinese medicine and acupuncture throughout the whole cycle as well. I think that it's important to also, prepare like preconception wise, just like you're doing IVF or naturally, because it's just as important. Just, maybe less medication, but we're still wanting to achieve the same thing, which is a healthy pregnancy. So I think that there was another question about IUI.
I'm just so happy our baby girl turned 5 months. Thank you for everything. I mean, like, it's so exciting.
Oh, congrats.
I know. Send me a picture. I want to see her. I want to see her.
Nice.
Yeah,
we like happy stories.
I know. Again, what I think, as far as the happy stories are concerned, I think when it comes to infertility, I think there's a lot of desperation. I think there's a lot of, this will never work for me. I think there's been a lot of people that have, told me this will never work. I mean, I just got a beautiful card today from someone who told me that she'd never have kids. And then she showed me a picture of her baby. And oh my gosh, she's got 4 more embryos in the freezer. And I looked back at her chart and I'm thinking, yeah, wow. When she came to see me, she had 5 miscarriages. Like 5 miscarriages. And she has a baby now. And like, she's got 4 others if she ever wants to come back for them in the freezer. But I'm thinking, wow, yeah, that does make you feel pretty desperate. So, I mean, you don't want to like flaunt pictures of babies and pregnancies in people's faces, but it's more like it's hope. Like, we have so many treatments. Like, we have and everybody's not like, this is not a one size fits all type of medicine. This is a type of medicine where we incorporate, little stuff, like just fertility timing. We incorporate, vitamins, we incorporate acupuncture. Like, there's just so much that goes that just has to like gel. And, people are sometimes afraid to at least see me because they think that like fertility specialists, oh my God, we just want to do high tech stuff. Like IVF is the only answer. Well, that's not the truth. There's sometimes really little type of stuff that we just tell people. I just had a patient the other day who, what did she tell me? It was something that they were doing that was just so simple. I'm like, oh, she was taking progesterone cream every day in her cycle. And I'm like, you can't do that. Like, progesterone is really meant to be exposed in the body, and the second half of the cycle, you expose the lining of your uterus to progesterone. In the beginning of your cycle, you screwed up.
You get confused, suppress ovulation.
Like, you screw up its receptivity if you have progesterone going on at the beginning of the cycle. And she's like, oh, I didn't know that. I'm like, well, let's just hope stopping that cream is going to be the answer, because she already has 1 baby. But she's, mild ovulatory issues and stuff. So, but I'm thinking it might be as easy as that, like simple little things that we try to look at everything. And again, nothing is kind of a one size fits all like approach, and which is where acupuncture comes in. So, you see these patients too, I'm sure.
Yeah, for sure. I mean, also, it's good for someone isn't good for everyone. So, like, if their friend might be like perimenopausal and they're using progesterone cream for hot flashes and that sort of thing, so they're using it throughout the whole month, but not for fertility. So we have to make sure,
Right. Again, so I'm not poo-pooing progesterone cream. I mean, for some people it makes them feel great, but they're not trying to get pregnant. Okay, so let's see. Question number 2 here. How successful is IVF for those of us with PCOS? Okay. Ridiculously successful. And there's no other answer to that question. There are certain things that we like our PCOS patients to do, in preparation for IVF to try and make their eggs healthier. But in general, PCO patients are an interesting crowd because you're not lacking eggs. You're lacking ovulation. Okay. So I try and help my PCOS patients, if they've got open tubes and good sperm, not do IVF. However, if we've done lesser type of treatments and they have not been successful, IVF is literally the panacea. I mean, it is the answer. I mean, PCO patients usually can make their entire family in 1 cycle. We can just make the embryos, freeze them, test them, and you can just come back and pick up the kids 1 by 1. So it does depend on age though, where PCO patients in their 40s, don't have as high a success as PCO patients in their 30s. Still, PCO patients in their 40s are still going to yield a multitude of eggs, which is going to lead to a lot of embryos, which is going to lead to, a lot of chances. So PCO in general, IVF is a great option. Problems with PCO and IVF are sometimes it does put you at risk for ovarian hyperstimulation. However, if we mature your eggs with the proper medicine, we can almost eliminate the chances of hyperstimulation. If we mature your eggs with a different medication, you might be at risk for hyperstimulation, if you're creating a lot of eggs. But, we're really conservative, and we are now able to help the PCO patient not hyperstimulate and achieve ridiculously high pregnancy success. So it's a great idea as long as you're essentially under the age of 43.
Yeah, for sure. And nowadays, I don't see that many hyperstimulation either.
Oh,
it's not
God,
as
I
common.
know.
Yeah, that was horrible.
It used to be, it used to be a monthly thing. We'd have a patient hospitalized, and we rarely see hyperstim anymore with the new trigger medicines that we use. Sometimes we get a little fooled, and if the patient's estrogen level isn't as high as we'd expect with the PCO, or we trigger them with the alternative medicine, and we don't use what we call a Lupron trigger. But the Lupron trigger has almost made hyperstimulation in the polycystic ovary patient a thing of the past, which is miraculous, in my opinion. But how do you treat PCO? Like, what you treat them along with us? So you have special acupuncture, points, and you help the PCO patient even before they get to IVF, correct?
Yeah, and I mean, we did have someone waiting to go to Spain to do IVF over the summer, and she couldn't go because of the pandemic. And we just did some preparation, and she ended up getting pregnant naturally. So it can happen a lot with PCOS. We find just using the right combination of vitamin D and working on the diet, working on weight loss a little bit, and helping a little bit with the acupuncture weekly sessions. But that was great. So it saved her a trip to Spain. Even now, I think it's still hard to go to Spain. But I think it's really important to look at all aspects, like the testing you guys do with the nutritionist there. It's so in depth for PCOS that I'm like, it's good to have that, looked at as far as inflammatory markers, all the things like that need to be addressed with PCOS that aren't often looked at with a regular checkup. And that's going to prepare for a healthier pregnancy, since there is a higher risk of gestational diabetes with PCOS. So if we can address that beforehand, that's great.
Yeah, it
and
makes
that's
the
how good.
pregnancy so much healthier. All right, so I just want to, I missed, like, as the feed goes on, I just want to check a question here. So this question was, and I'll go back to the other questions that were submitted previously. I'm 42, I failed IUI recently. Previous IVF 7 years ago failed as well. What would be blood tests and other tests that would be done that I would have done absolutely necessary before I would do another IVF? Again, egg reserve. So testing egg reserve is going to be number one. Testing your values of AMH to see how many eggs you have, testing your FSH. And then again, it sounds like you've had a long infertility history if you've done an IVF 7 years ago. So clearly 7 years ago, you weren't 42. Okay, 7 years ago, you were 35. Okay, so before I would do another IVF on you, I would work you up for implantation failure issues to figure out why a 35-year-old didn't get pregnant with IVF and why a 35-year-old hasn't got pregnant in the 7 years following her failed IVF. So there are a lot of tests that I would do on you prior to say, oh yeah, another IVF is the answer, okay? Because if I do an IVF on somebody, hell, I want it to work, okay? Or I want it to at least give it the best chance of working. We've got a multitude of factors to make an IVF work. We need a normal embryo, so that's gonna be something we discuss. We need a healthy uterus, something we discuss. We need an immune system that's not gonna reject an embryo, something we can discuss. But, where IVF is our best treatment out there, okay, we just don't like go into it and say, yeah, this is gonna work, okay?
Mm-hmm.
We go into it with an evaluation done saying, I've covered this space, I've covered this space, I've covered this space. Now you're gonna have your best chance of success. So there's a bunch of stuff, just, long answer to a short question essentially, but there's a bunch of stuff that I would absolutely recommend before just diving into another IVF. And then where do we go here? There's one more, and then I'll go back to the ones they submitted earlier.
And we have a Facebook question too.
Oh, we don't have it.
Okay.
Yeah, let's go with that. So I got a couple questions up here.
Okay. What are your thoughts on pre-prom pregnancy loss and the chances of it happening a second time?
Well, again, I practiced obstetrics for 7 years. Okay. So again, and I love delivering babies. It's just the sleep deprivation was a little too much. I mean, delivering babies is like such a rush. It's the funnest thing
Yeah.
ever. So pre-prom means the membrane's ruptured early, and it depends on when they rupture as to when the baby is going to be viable. Okay. Most of the time, early rupture of membranes is going to be caused by some sort of infection. And so there are aggressive ways to approach the next pregnancy as far as trying to identify whether or not infection is going to be a factor. And I have one little girl out there that, again, it was little bit out of the scope of my practice, but I went above and beyond for this young lady. She had had so many early PPROM losses for infection. I mean, I was actually culturing her every 3 to 4 weeks in my office. And we actually found an infection at 22 weeks. We started treating with antibiotics. We kept the antibiotics going, and she ended up delivering the baby at 26 weeks. But we had her on antibiotics along with the high risk doctor and the other doctors. And her baby was delivered prematurely, but she's fine now. But infection is one of your major causes of this. And as long as you're working with a perinatalogist and OBGYN who is addressing, the high incidence of bacteria in the vagina, it just has to be addressed. We address it in our practice because, again, we know it's important for implantation. So we have a very extensive probiotic regimen that we use vaginally as well as orally to try and maximize the health of the bacteria in the vagina when we do our frozen transfers, when we do our embryo transfers, when we're treating patients. So we really, address this very, very aggressively. But I think a lot of the PPROM stuff has to be addressed with the OBGYN because we're subspecialists. So, we see patients with problems. When you're going to your OBGYN, which, are great doctors, all these people see as babies. I mean, again, the complications are like a minor part of their lives. So when you have a case that you've had a problem in the past, try to address it with your OBGYN and say, look, this is what happened to me before. What do you think about probiotics? Should I continue them after my IVF? What do you think about doing extra vaginal cultures? Things like that. Again, I can't speak for them. I just know that when most PPROM is for infection, and there definitely there's a link there. I mean, there's clearly a link with bacteria, vagina crawling up and infecting your water bag. So hopefully I answered her question. But it's infection.
She wanted to know if there was a fertility link, she said, because she said she had no infection until after rupture, according to pathology.
Yeah, so this is where we're seeing uterine infections and so at this point, if you're trying to have another baby, you should have an endometrial biopsy done and get checked for a condition called chronic endometritis, which means that there's bacteria that's basically crawled up into your uterus. It's made a little hole in there, and it's causing a chronic inflammatory condition inside the uterus. So yes, there absolutely is a connection, with these things throughout pregnancy. It's just pregnancy care is kind of disjointed because, we take care of you till 8 weeks and send you on your merry way. And then, the OBs have a different perspective and the high risk doctors have a different perspective. So yes, infectious etiology is a big thing. And I would get your cervix cultured with a culture for, we call a uniswab. It has, 12 different bacteria in it. And then I would absolutely undergo an endometrial biopsy and make sure that there's not bacteria that are just kind of hanging out in your uterus. And this can be treated. And this can be treated very easily with, a couple weeks of antibiotics, and then you recheck the cultures and you recheck the biopsy to make sure that things have been eradicated. And then this will give another pregnancy its best shot.
Thank you, Heather. And I hope that we are crossing our fingers next pregnancy will go much better. But thank you for your question. Sorry for your loss.
All right. Yeah. So, okay. So, do you recommend, this is a question that was submitted earlier, do you recommend a saline ultrasound before undergoing IVF? Absolutely. That's a no-brainer. So as I said earlier, we need 3 things to go right in order to get pregnant. We need a healthy embryo, okay? We need a healthy uterus. So we do biopsies and we do saline sonograms to make sure there's no growths in the uterus. If you have a polyp, if you have fibroid, if you have scar tissue, if you have anything inside that uterus, it's going to lower the chances of an embryo implanting. So saline ultrasound is a non-invasive, which I mean by non-surgical, means of evaluating the inside of the uterus for health. And so absolutely, we do them every 6 months because we do see the results change.
Hmm. Yeah, I picture them like, you know, a spaceship landing on Mars and surveying the terrain. It's like, okay, there's some good favorable place for landing, you know, but I think it's one of the coolest tests that.
Yeah, so it's only got 5 minutes in the office and we can evaluate whether there's a lump or bump in the uterus that could cause implantation failure or miscarriage. All right, so we've got another one here. How do you feel about the ERA after a failed second FET? Okay, so ERA study just came out looking at ERA before we do anything. Okay, doesn't help. Okay, it does not make a difference in live birth. So I think just doing an ERA to do an ERA because we can. We've done frozen embryo transfers the same way, you know, for the last 40 years, you know, estrogen, progesterone, put the embryo in. But I think in the face of having an embryo now, if the embryo was tested, it's a different story than the embryo was not tested. Because if the embryo was not tested, depending on your age, the embryo was created, depends on the health of that embryo. If you had a failed frozen transfer of a normal tested embryo twice, completely different story than if you had a failed frozen transfer of an embryo that wasn't tested, because we put the blame on the embryo. In these reports we get back, when we test the embryos, they make my jaw drop. So patients will have 5 embryos tested, only 2 are healthy. The thing is, they all looked beautiful. So I wouldn't know unless I tested which ones were healthy and which ones weren't. So if you had 2 frozen transfers of untested embryos and we came out and said, oh my gosh, embryo perfect, it's beautiful, it's the most beautiful blasts I've ever seen, and we put it back in, could still have extra chromosomes, could still be abnormal. So if you had a failed frozen transfer of two times of a tested embryo, I think ERA is probably a decent thing to think about. Maybe again, you have a receptivity issue, and you need to customize the amount of progesterone that your body is exposed to before transfer. So not a bad idea to talk to your doctor about. All right, let's see on the screen here. How high are the chances of having triplets with 3 dominant follicles? Really depends on your age. Okay, if you have 3 dominant follicles and you're 25 years old, well, it's possible. If you have 3 dominant follicles and you're 42 years old, you're probably not going to have triplets. So the health of the egg is what makes the difference. So the older you get, the more unhealthy eggs you have. So even if you have 3 follicles, the likelihood of you producing 3 healthy eggs is extremely low. If you're 25 years old and you have 3 follicles, the chances of you having 3 healthy eggs is, it's kind of high. I really can't give you percentages because I haven't had triplets from oral fertility medicine in a while, no, like ever. But it is possible. And then the type of medicine you took to have those dominant follicles, whether it was Clomid, Femara, or injectable drugs, that also makes a difference because that alters receptivity issues. So the chances are quite low. However, they do exist. I would give you a 1 to 3% chance range that you could have triplets, but not knowing that's not knowing your age. Okay, so that was that one. All right, so do you have other, no, Facebook, no, we're good there. Okay, so another question that was submitted earlier. Is it true that babies born via IVF are at higher risk for heart defects? Okay, so this is true. However, you have to look at the raw numbers. So when you look at the raw numbers, okay, we are talking about very, very, very low numbers. So there was a meta-analysis done in 2018. So a meta-analysis means that we compile like gobs and gobs and gobs of medical literature together, and we lump it all together and we see, all right, if we don't lump this amount of studies together, what do we come up as far as a conclusion? So the study that this patient is asking about is a meta-analysis, and let me see how many studies they lumped together. 41 studies, okay, were identified. 6 were case controlled, 35 were cohort studies, okay? And basically they looked at these studies and they looked at the children of IVF and the children that were spontaneously conceived. So of the children that were IVF, 337 out of 26,000 had a heart defect, okay? We don't know how severe the heart defect, but had a heart defect. So, which is 1.3%, all right? So 1.3%, extremely low. Then they looked at patients who were conceived spontaneously, naturally. And of those patients, there was almost 2,000 babies with heart defects that were conceived spontaneously, 2,000 babies, but this was out of 287,000 women. And so statistically, that was 7%. 0.7%. So when you look at 0.7% in the spontaneously conceived pregnancies, and then it's 1.3% in the IVF pregnancies, this is news, okay? So this is like, twice the rate of heart defects. However, are patients doing IVF for fun? No.
Mm.
People who come to IVF have problems. I mean, people aren't coming into my office rarely, just for fun. So there's an underlying component to that couple as to why they're not getting pregnant naturally. I mean, when we look back at Darwin and we look back at survival of the fittest and who propagates the race and who doesn't, what we have to look at is that there's some patients who are going to be able to reproduce with the help of these higher technology that might have been weeded out of the race because they have some sort of something in their genetic makeup that's going to predispose them to having a birth defect. But if you want a baby, to take the chance that there's a 1.3% chance that maybe my baby will have a heart defect, but a 98.5% chance that they won't. I mean, let's look at the cup half full here, okay? 98.5% chance my baby will not have a heart defect. Yeah, I do IVF, okay? I've recommended IVF for my friends, my family, my staff, okay? And when I look at something where my benefit is, I'm going to have a baby where nothing else is working, and if I don't do IVF, I'm never going to have a child, versus, well, I'm going to take that tiny risk that, but when you look at it news-wise, it's double. I mean, the raw data, you have to look at the raw data because, again, double sounds scary, and 1.3%, in my opinion, does not sound scary. So, and just getting sex, 0.7%, your baby could have a heart defect. 0.7%, that's almost 1%. Your baby get a heart defect. And people are having sex all the time and having babies. So, I mean, I think you have to look at these things from a numbers, like a raw number perspective. But, this type of article makes news. This type of article scares people, but it makes news. So, in my opinion, to take the risk of maybe a 1.3% chance versus never having your own child, I would take it. I've had my family members take it. I've had, friends. So again, this is just, sorry, long answer to a short question, but I wanted to kind of explain it because it's something that is on the internet. I mean, you read it out there and you're like, oh my God, IVF is so scary. IVF is a means to an end. Okay, IVF is a way to have a family, a way to have a child if nothing else is working. And that's the way we use it. It's, we don't do this for fun. I mean, we do this, we recommend this, to help you have a family, and it works great. And, thousands and thousands and thousands and thousands of babies. I think I read some sort of statistic somewhere, I think maybe Australia, that 1 in 25 babies is IVF now, or something crazy. I think in the US it's like 1 in 70, but in Australia it's like 1 in 25. I mean, it's just,
Oh, wow.
yeah, no, it was something I was like, my eyes kind of, popped out of my head when I read it. I'm thinking, that's kind of crazy. But in Australia, it apparently costs $5,000 for an IVF cycle. So it's fairly economical. Yeah, there. One other question here. I'm new trying to conceive, 35 and a half. I think I have low progesterone. Do you recommend Vitex, maca root, raspberry leaves? I think Vitex is a decent product. What I would recommend would be, first of all, looking at body mass index. I would look at lifestyle habits. I would look at, whether you get a positive ovulation kit, what your progesterone levels are, because there's so many lifestyle factors, and I'm going to have Dr. Duro address this a little bit more, that can improve the strength of your ovulation without fertility medicine. So if your BMI is, over what it should be, that extra weight could be causing your progesterone level to be low and causing your ovulation to be poor. If you don't have good circulation to your pelvis, which acupuncture can help, that can cause poor ovulation. I mean, 33 and a half, that's young. That's young. So again, we're supplements. I mean, I'm not I'm a medical doctor. I prescribe medicine, but I look at lifestyle, and I don't think, raspberry leaves potentially would have a huge impact on it, but it's a global thing. We have to look at, what else is going on in your life. Just taking a supplement isn't going to be the answer. What's your exercise routine? What's your diet look like? What's your BMI look like? So many other things. So I just wouldn't say, oh my gosh, my progesterone's low, I'll take some of the supplements and it'll be better. Dr. Duro, your thoughts on that?
Yeah, I mean, these things that you mentioned, they work slowly over time. And Vitex can help increase LH, which also can, help with ovulation and progesterone, but that takes many, many months in my experience. It's one of those very slow acting things. But the main thing that also can help with the progesterone is addressing stress, and stress can cause your cortisol to actually go up. Yeah, and so your body's actually stealing your non-essential hormones like progesterone, which the body doesn't prioritize, unfortunately. So it will actually, make more cortisol instead of progesterone. And so if we look at yes, yeah. So if we always look at, the picture of trying to get back into parasympathetic mode and trying to help with that fight or flight response, which also might be causing issues with ovulation and hormone production and many things. So I think that is a good suggestion to figure out why it's low, and then kind of go from there as well, so that you don't end up like spinning your wheels and losing time, because time is so important for fertility, and so maca also, it's one of those adaptogenic, like hormonal adaptogens, so it can kind of, over time, again, it takes a long time to actually figure out what your body needs, but these herbs act in that way, sort of like a ginseng, that sort of thing. So and red raspberry too, but again, very, very gradually. So there's definitely like more targeted approaches to take. And since you're new to trying to conceive, it can feel super overwhelming, and that's why we're here. I get it. And if you ever want to just explore that more, I think it'd be great to do a consultation or with a provider, or get your hormones checked. You can even start with your OBGYN if you like, but or go to Dr. Webb, because they do a very thorough evaluation and they can do an ultrasound to see if there's something that's preventing your ovulation from happening, and maybe that's why your progesterone's low and you're not getting pregnant. So.
All right, yeah, excellent. All right, so I just want to answer a quick question. After successful pregnancy with IVF and baby's 5 months, what will be the next step? We have a frozen embryo transfer. Okay, so it depends on the way you deliver. If vaginal delivery is 6 months, you could start. C-section, I won't transfer before 9 months. If you're breastfeeding, you need to wean breastfeeding. So simple. We recommend breastfeeding for 9 months to a year. So, most of our patients will come back to have another baby. At 9 months, we'll start and we'll transfer by a year. If we've weaned the breastfeeding and we've had a vaginal delivery before, we can probably transfer embryo at 9 or 10 months. postpartum, as long as all the blood work looks good and, the hormone levels are good and, we have the embryos and stuff. So I do, again, start 6 months for vaginal delivery, 9 months for C-section, and then, but we have to wean, the breastfeeding. So it would be possible to have your kids pretty close if you have vaginal delivery. So hopefully that answers that question. All right, so we got a couple more that were submitted earlier. So I'm gonna try to get to those. Okay, so the one question is, why do you think some embryos result in aneuploid? Okay, this is not a hard question. So what does aneuploid mean? Aneuploid means that the embryo has too many chromosomes. Okay, what are chromosomes? So chromosomes are the things that come from the sperm and come from the egg. Sperm are manufactured with 23 chromosomes. Eggs, on the other hand, start off with 46. Okay, so this means an egg has 2 pairs of every chromosome in it. So what has to happen as that egg goes through its maturation process, chromosomes have to line up. Okay, so these chromosomes, little squiggly things in your cells, they have to split. So 23 pairs of chromosomes have to split simultaneously and get pushed out of your egg, leaving your egg with 23 chromosomes. Okay, that's a lot. Think about it. I mean, the amount of stuff that has to go on the cellular level to get 23 things to migrate out of your egg at the exact same time when the egg realizes that there's HCG or LH present. It's amazing anybody has healthy babies. Honestly, amazing. So, aneuploidy means extra chromosomes. Extra chromosomes usually come from the egg because the chromosomes are too sticky. So 22 chromosomes leave your egg, leaving 24 behind. Egg is 24, sperm comes in with 23 because it's possible for sperm with extra chromosomes to penetrate eggs. It's just not likely. It can happen, but it's not likely. Most of the mistakes that cause aneuploidy occur from the egg because there's so much has to go on in the egg. So the sperm coming with 23, egg is 24, now we have 47. Depending on which chromosome was left behind depends on how far that potential pregnancy will get. As you age, your cells get weaker. There are things in your cells called mitochondria. Mitochondria are the little engines that drive this process. So engines in your cells are what say, all right, come on chromosomes, let's go. Come on guys, get in line. Let's get in line, 23 of you have to go. And so they're what drive the 23 chromosomes to line up and leave. Your mitochondria get weak, wrinkles and gray hair. Okay, it's just reality. So what we try to do with our vitamin supplements and things is we try to strengthen your mitochondria so that your chromosomes will like get in line and 23 will march out of the egg at the time of ovulation or the trigger shot if we're doing IVF. But age and weakness in your mitochondria is what causes the eggs to, in general, have a higher degree of aneuploidy. And that's just the truth. It's something, it's generalized aging, which is why we see 50% of the embryos are healthy and euploid or normal in your 20s. And in your 40s, we only see 10% and max 20%, of your embryos are normal. It's because your mitochondria are weak and they didn't kick out enough chromosomes. So that's explains it. So it's physiologic. It's just the aging process. And again, there's all sorts of things we try and do to defy the aging process. The problem is I don't have hair dye or Botox for eggs. I have vitamins, I have acupuncture, I have blood flow, yeah, I have nutrition, I have lifestyle, I have things like that. But I don't have things as good as, again, Botox and hair dye for your eggs. So the things that we do recommend are meant to strengthen your mitochondria, are to make you healthier, are to improve blood flow to your ovaries, are to improve nutrition to your ovaries, and hopefully that will support your mitochondria to help you create healthier eggs. So hopefully I answered that for the patient.
We love that explanation. I was just picturing the little mitochondria.
I know. I was like, I just like, line up, guys. Line up, guys.
I just took a course on laser acupuncture to improve mitochondrial health with fertility, and so we've been using laser, and it's pretty exciting with the treatment. So there's many, like, couple ways, but yeah, I mean, it's definitely, I guess, you know, evolutionary wise, we didn't live this long before, so that's what's happened.
Let's see, where's that next? On this feed, does OBGYN do blood work before prescribing Clomid, or do I go straight to a fertility specialist for testing, or could Clomid be prescribed without blood work? Honestly, it depends. It depends on whether you work with your OBGYN or whether you work with a fertility specialist, okay? OBGYNs, there's some of them that love fertility. They really are. Like, they did a really great, you know, fertility rotation as a resident. You know, they like it. They enjoy helping patients get pregnant. Because most of the patients they see are pregnant. So it's not really, you know, some people it's not a passion to like go see the fertility person. But if your OBGYN enjoys it and you're young, there's no reason why you can't work with your OBGYN. If you're over the age of 35 and you're having difficulties getting pregnant, just go to your fertility specialist. I mean, it's just going to make your life so much more efficient. And we're going to test those hormones. We're going to test everything before we give you Clomid. I mean, I've seen patients in the past that have done, you know, 6 months of Clomid with their OBGYN, and they come to me and I check their tubes and their tubes are blocked. Well, that was just a wasted 6 months. Especially if you're older, this could really be, you know, a make or break in your fertility journey. So, I mean, we are very comprehensive, but there's no reason if you're young and your problem is clearly ovulation that an OBGYN can't, you know, help you. But if there's any sort of complications, or if they don't do a full evaluation before they prescribe you the Clomid, then you really should see, you know, your local fertility specialist. Let's see. So, okay. Oh, she did ask this last week. I heard this last week. Is the PGS normal embryo trump its embryo grade? Okay. Okay, so as was answered last week by Dr. Rosef, I mean, you know, grade is everything. You know, you look at like grades in school. You get A's, you're like, that's the smarter kid. You know, if an embryo is a BC, yeah, we don't think it's as good. But in general, so it's a PGS normal embryo. Our practice looks at grades of embryos, and we have determined that in some cases, the day of the biopsy, whether it was a day 5, day 6, or day 7, matters. And we've also looked at grade, and we see that the grade of the embryo does seem to have an impact on live birth. So when we look at things in our hands, okay, we would always advise to transfer the higher grade embryo. However, that's not an absolute. The numbers, again, we're compiling numbers, and when we look at grades of embryos that were, if we look at a grade of an embryo that was tested on day 5, and then a grade of an embryo with the same grade that was tested on day 6, we do see a difference in live birth. So there's little subtleties. So essentially, the embryo grade doesn't make a difference since the embryo grade was determined at the point of time. If the grade was determined later that day, it could have changed. Exactly. That's exactly what I'm saying. So, you know, PGS at least puts us on an even playing field. But at the end of the day, we have 5 PGS embryos. Okay, they're all normal. Who are we going to pick? I mean, are we going to do eeny, meeny, miny, mo? Okay. And like, you know, and then close our eyes and decide like which one's going to be better. We have to have criteria okay, to say, all right, we're going to pick this one over this one. We're going to pick this one over this one, because there is a difference with how they look. So our practice likes to look at morphology, which is the grade of the embryo, and say, all right, well, I've got 5 embryos. So you just put in front of an embryologist 5 pictures of embryos, okay? And you ask the embryologist, which one are you going to transfer? They're going to say, all right, well, this one has a chunkier baby part. This one has a chunkier placenta part. It gets a better grade. Obviously, I'm going to pick that one. And yes, the medical literature has supported that, you know, the more cells an embryo has, the better chance it has to achieving a live birth. Doesn't mean the lower grades aren't going to make a live birth, but if we want to, we have to have some criteria on how to pick somebody, as opposed to, you know, just picking a number out of a hat. We're going to transfer number 4, there's embryo number 3. So that's where we use grades. Okay. If somebody has a gender preference, okay, and you know, the gender they prefer is a lower grade embryo, I still would go with the lower grade embryo. It was biopsied, it was frozen, it's still a pretty darn good embryo. I mean, if it had to go through all that. Mm-hmm. And so I wouldn't say, you know, well, pick the boy because it has a better grade. If the girl doesn't have a best grade, I want my best chance. If you have a gender preference, yeah, that's where I go with. Otherwise, I'd say, hey, I don't care. I just want a baby. You guys pick the embryo you think is best. We're going to pick the embryo that was biopsied earlier, you know, at day 5. Or day 6 over day 7, and we're going to pick the embryo with a better grade, because we want to give you your best chance. Okay. But I wouldn't, if I wanted something specific, I wouldn't, they're all on the even playing field as far as as far as I'm concerned. My pregnancy, I've looked at my personal pregnancy statistics, and I just look at live birth rate. I don't quantify it into grade, and my live birth rate is almost is pretty equal, whether it was biopsy, whether it was a, you know, an AA or a BC. So I don't think it, you know, that's a huge you know, issue. Let's see. Oh God, we're running out of time because I'm talking too much. I guess this one's supposed to do that. Let's see. We got a couple questions here. Let's see. We did that one. FSH 33. Yeah, FSH. I don't know. FSH 16.5, AMH 0.4. Do I have any luck on IVF? Depends on your age. Okay. If you're in your 40s, you know, little tight. If you are a 32-year-old with an FSH of 16 and AMH of 0.4, yeah, I can get you pregnant.
She's 33, I think. I think it says 33.
Oh, no, 33. It's 33. I thought,
yeah.
33. Oh my God, 33. Yeah. Absolutely, you can get pregnant. Oh my God. Like, no, I treat patients, not numbers. I mean, no, yes, you have luck with IVF. I have a lady now.
Go for it, girl.
Oh my God. I know, literally. I have a lady, 33. I think she's maybe 32, 50. Same numbers. Okay. She's got 2 normal embryos frozen in the freezer. Okay. 5 eggs, 4 FERT, 4 biopsy, 2 normal. Same numbers. Same, like literally crappy numbers. Okay. 2 normal embryos. I mean, it may take 1 or 2 tries, but yeah, don't, if you're only 33, no. At 33, age trumps bad numbers any day.
Yeah, and those numbers are fluid. I mean, they can definitely change, like fluctuate a lot.
Yeah,
I mean,
they're not the greatest numbers, but no, there's no way you shouldn't try. I mean, you should prep you and make you healthy and I mean, all sorts of stuff, but there's no way those numbers can ever say that you won't have a baby, ever. All right, let's see what else we got. 31, no fertility factors. What percentage of embryos can be expected to be abnormal in PGS report? 60%. So we expect 50% of our embryos in your 20s to be normal. We expect 48% of our embryos to be normal between 30 and 34. We expect 30% to be normal between 35 and 40. And then only 20% to be normal at 41, 42. Less than 10% over that. So even though patients have no fertility factors, eggs are a product of age. So 31, great chance of making normal embryos. Okay, so it's just, you know, hopefully your hormone levels are good, but as I said, I have someone with hormone levels that weren't good, and out of 5 eggs, I ended up with 2 normal PGS embryos. So age trumps everything in this business. Is SSG more clear than HSG? Okay, so I'm assuming we're talking about water ultrasound versus HSG. HSG really is mainly for tubes. So HSG will evaluate the uterine cavity, but we don't have the ability to go like this, to kind of turn it around like we do with a 2D or 3D ultrasound. So with the 2D or 3D ultrasound, we can look at kind of the walls of the uterus. The X-ray, the HSG, is just a flat image of the uterus. So whereas we can get an idea of the contour, kind of the way the uterus looks, we can't see really if there's lumps or bumps in it. So the HSG is really used for the tubes, and the saline sonogram is used for the uterus evaluation. And again, the question says, we do saline sonograms on all our patients undergoing IVF. Now, if the patient has the possibility of having a tubal factor, okay, so maybe the tubes might be blocked, and HSG would be important, because if you have fluid in your tubes, okay, the fluid in your tubes could potentially cause implantation failure. So a lot of times I will recommend an HSG plus the water ultrasound to improve the chances of because some people say, oh, you don't need to evaluate the tubes, you're doing IVF. But if there's fluid blocked in the tubes, it'll prevent the embryos from implanting. Oh, my wife turned, oh God, I'm running out of time here.
Lightning round.
Lightning round. My wife is so torn between whether she get the COVID vaccine before transfer. What advice do you give patients who have vaccine and conflict for fertility factors? Well, it depends on your transfer schedule. So the problem is with the COVID vaccine. So you get your first dose, most people aren't having a reaction to it. You get your second dose, okay, within 2 to 5 days, some patients are having fever. They're having that sweats reaction because your body's having the immune response, okay? We prefer you not to be in your fertile window when you're having that. So, you know, if you're gonna get the vaccine because you're in a high-risk profession and you're exposed to a lot of people, where essentially the benefit of getting the vaccine is going to outweigh the risk, okay? Risk being getting COVID during pregnancy, which has been shown to have pregnancy complications in the second and third trimester, okay? So preterm labor if you get COVID during pregnancy. So, I mean, there's issues with COVID in second trimester pregnancy, not first trimester, second, third trimester in pregnancy. Has not been shown, COVID in pregnancy has not been shown to increase the miscarriage rate in the data that has been published so far. But if you get COVID, it can lead to preterm labor. It can lead to pregnancy complications in second, third trimester. So therefore, you're in high risk, you're pregnant, you're at risk to get the COVID, you might want to get the vaccine. But you want kind of the vaccine on board like before you get pregnant, because you might have fever, you might have sweats, you might have some sort of reaction to the vaccine, and we really don't want that in that window where you're conceiving, you know? I mean, I get super concerned when patients are getting sick when they're potentially going to, you know, be pregnant, or I put the embryo in, they say, oh my God, I got the flu after I put my embryo in. I'm like, well, that's terrible, that shouldn't happen. So, you know, yeah, the timing is very, very important here, and the patient has to assess the risk of getting COVID, you know, and the risk of the 1 in 90,000 I think it's 90,000 adverse reactions in the vaccine. So again, very, very complicated question. So everything is very, very individualized. So anyway, we're 8:29, okay? Hopefully everybody will be back next month as far as asking questions. This was awesome. I'm sorry I couldn't get to everybody's question. Again, I'm Dr. Ellen Wood. I just wanna let you know, thank you for being here. I'm at Dr. Ellen Wood on Instagram. This is Dr. Duro. Thank you so much for taking care of our patients, improving the blood flow, helping them with nutrition, helping them with all of their fertility issues. Your treatment is so crucial to what I do and helping my patients have babies. This was great. Hopefully everyone is following me on my Instagram and my Facebook page. And Dr. Duro, say goodnight to everybody, because I think
Thank you. Thank you, Dr. Wood, as well. Okay, thanks guys. Florida Complete Wellness if you'd like to join us. Bye. Bye everybody on Facebook.